Well, hello and welcome to you all to an industry-sponsored symposium. This is the Endologics-sponsored symposium on probably one of the most important topics of endoluminal aneurysm repair, the durability challenge with EVAR. In this symposium, we're going to look at the drivers of adverse events and what does the 5-year data say about polymer sealing technology. And I'm delighted to have two colleagues who really need no introduction on this topic, Professor Matt Thompson from Irvine in the United States and Professor Hens Verhagen from Rotterdam in the Netherlands. Matt is going to discuss transforming the treatment of aortic disorders, and then Hens will really focus on the durability challenge for EVAR. What are the drivers of adverse events and what does the 5-year data say about polymer sealing technology? I'm then going to share with you a case presentation of our first commercial case using Ovation ALTO. Now, these three presentations will run one after the other, and then I'll close the session. So without further ado, let's hear from Professor Matt Thompson discussing transforming the treatment of aortic disorders.
I'm going to give a short presentation from the Endologics perspective on the transformation of the treatment of aortic disorders. Clearly, given my role as Chief Medical Officer with Endologics, I have some potential conflicts to declare during the presentation. So let's start at the beginning. If we look at the history of aortic surgery, there have been a huge number of innovative and transformative procedures and thoughts that have moved us from simple ligation of aneurysms in Hunter's day to packing with wire and inducive electric currents to induce thrombosis, through wrapping of the aneurysm, as was done to Albert Einstein, through open surgical repair, and today into endovascular repair. And if you plot out the timeline of those transformations, you can see how we got from peripheral aneurysm ligation by John Hunter in 1789 all the way to the present day, where I think most of us would agree we're in an era of traditional EVAR surgery. But it probably does help us to remember that it's getting close to 30 years now where we've been using essentially the same technology without any transformative leaps to repair abdominal aortic aneurysms. Some of the very first EVAR grafts used in the abdominal aorta were predicated on self-expanding stents that were covered in either PTFE or Dacron and were usually oversized 15 to 20% with regard to the diameter of the aortic neck. Now, we've clearly made advances since those early endografts in materials, but the general thought process remains relatively the same. And that does mean that the failure mode of one endograft is likely to be replicated by the failure mode of another endograft. So if you think really why we transitioned largely from open surgery to EVAR, that was predicated to a great extent on the short-term outcomes that EVAR was able to achieve with a reduction in mortality and morbidity. And because of those short-term outcomes and the drive of patients for improved short-term outcomes, the trend from open surgery to EVAR is unlikely to be reversed. However, as I showed in the previous slide, most endografts have relatively similar design principles and are based on a modular device with an oversized self-expanding stent to achieve proximal and to a lesser degree distal seal. These endografts do have relevant clinical mid-term failure modes that impact their efficacy. This is design related and it has led to considerable discussions about the durability of traditional EVAR in the last few years. From the Endologics perspective, we feel that new technology is needed, could be based on anatomical adaptation without the needs for oversizing, and that this may show improved durability, but quite clearly any transformative leap in technology or innovation these days will need to be proven in a randomized controlled trial. But if you could show improved durability with equivalent short-term outcomes, then surely that would drive adoption of any new technology. So when I speak about the unmet needs of EVAR, what am I talking about? Well, we know now from the randomized trials and also some long-term longitudinal studies that traditional EVAR confers no overall benefit in all-cause mortality or indeed aneurysm-related mortality when compared to open surgery. We also know that EVAR is associated with a higher rate of aneurysm rupture when compared to open surgery, and this deterioration in results occurs around the first year after implantation. We also know that now 50 to 60% of patients are alive 8 to 10 years after EVAR, and therefore the durability that was often forgotten, to be fair, in the early days of EVAR has now become paramount. And recent long-term studies had shown that a third of patients getting EVAR require reintervention at 10 years, and the rupture rate in patients requiring reintervention is reported at 20%, but the true rate is likely to be higher than that. In terms of innovation, there's been a lot of emphasis placed on low-profile endografts, but these have performed relatively poorly in clinical science. And then I think of significance for the future. We know now that aneurysm sac behavior post-EVAR is predictive of outcome, both in terms of rupture and in terms of all-cause mortality. So I tend to think of this now as a hierarchy of outcomes. When I started doing EVAR 25 years ago, I really did think that we would impact the top of this pyramid. I thought that EVAR would translate to a reduction in all-cause mortality, certainly a reduction in aneurysm-related mortality and the complications of having aneurysm repair. But really that hasn't transpired to be true. All we can say at the moment is that traditional EVAR is probably easier on both the patient and the surgeon. And what we've really got to do is think about how we can impact the top layers of this pyramid. And that's really where I come to Endologic's technology and innovation pipeline. This really is innovation to try and address the unmet needs of EVAR that I've just described. So this is Endologic's current product portfolio. Endologic's grew by a series of mergers and acquisitions, acquiring Nelex and merging with Trivascular, and therefore the company has 3 infrarenal products. And actually, candidly, over the last 2 or 3 years, we've been thinking about how one would position these products. And really it comes down to ALTO, the new polymer-based endograft with an anatomically adaptive seal, being a pivot in trying to evolve traditional EVAR. So Endologix has AFX2. This graft, in terms of a design, has been around for a long time. If you like, it is a conventional EVAR graft, although its fixation is anatomical on the aortic bifurcation, rather than active fixation either suprarenally or infrarenally. However, this graft has been compared to other comparator grafts in a randomized clinical trial, the Leopard trial, and actually the performance is equivalent, if not slightly superior in certain aspects. AFX2, as we know, has utility in specific anatomical locations. But what we really want to move on to, and this is a process that takes years, not months, is a more differentiated solution that is designed to try and improve durability. ALTO's just received a CE mark and FDA approval and has been launched in the USA. It will shortly be launched in Europe. The importance of this platform is that the seal is separated from fixation, it's anatomically adaptive, and it is not reliant on self-expanding stents for seal. Data of the previous Ovation platform has shown very good durability and certainly enhanced durability in situations where traditional EVAR may struggle, in patients, for example, needing the largest diameter devices. This has been achieved with a low-profile graft because with the use of polymer, one doesn't need to pack stents and fabric throughout the length of the delivery sheath. And ALTO has broad, excellent patient applicability that should translate to excellent outcomes in both the near and long term. So why is ALTO the pivot? Well, ALTO is the pivot because in due course we want to move into EVAS, and this may truly be a paradigm-altering design. There's been a lot of learnings with NELIX since its launch in 2013. The anatomical IFU is now very significantly constrained because we understand the necessity for a large flow lumen in order to stabilize the graft. The results that we're seeing out to 5 years with on-label patients with a good procedure in the EVAS-1 trial are good, but I suppose the most exciting aspect of NELIX is that it creates a new paradigm of aneurysm sealing, and we do know that sealing the flow lumen inside the aneurysm and not allowing continued perfusion of the aneurysm sac appears to relate to a slightly different biological response to surgery that may have significant long-term implications in terms of all-cause mortality, but this remains to be proven in a clinical trial. Endologic's pipeline portfolio is a next generation of the EVAS platform, taking, if you like, some of the best aspects of the 3 existing Endologic's infrarenal grafts and combining them into a next generation EVAS platform, whereby physicians will be able to separate and independently manipulate arterial fixation, proximal and distal sealing, and aneurysm sac filling. Now, this is an ambitious portfolio, and it needs to be backed up with robust clinical evidence. We believe very strongly in a robust clinical evidence pipeline and will subject both our existing and future technologies to randomized controlled trials. As I mentioned earlier on, the LEOPARD trial is the only randomized controlled trial that actually pits one endograft against another. It puzzles me as to why we've not seen more comparative studies in the literature, but this was a study that delivered a lot of learnings. It did show in terms of clinical results that AFX performs equivalently really to all the other comparators on the market. The anatomically adaptive seal using polymer has been studied in the long term in the ENCORE registry. This is a 1,300 patient registry with 5-year follow-up and shows very good durability of this sealing mechanism. As I said on the earlier slide, we've just about launched ALTO in both the US and the European Union, and we plan to subject ALTO to a randomized controlled trial against the current comparator endografts. We will start to enroll this trial in Q4 of 2020. It'll be a similar design to LEOPARD with a 2-to-1 randomization ALTO versus the comparator endografts. We'll be looking at morphologic endpoints in terms of aortic neck dilatation, as well as the more meaningful, perhaps, clinical endpoints that we traditionally see in these studies. Finally, with regard to EVAS, we see this as a therapy, not a product. We have just evaluated the NELIX 3.5 graft in the EVAS 1 and 2 IDE studies and are preparing the PMA application for NELIX approval in the US as we speak. The ability to combine EVAS in terms of NELIX with chimney grafts has been evaluated in a post-market registry in Europe, but we're now endeavouring to study this prospectively with the CHIVAS-1 IDE that will be a global study and will start to enroll in the next few weeks. So finally, I want to end on this slide. There's been a lot in the news about Endologix in the past few months. As I think most of you know now, we've entered a process to become a private company, and we hope to exit that process at the end of September this year with a clear commitment to an innovative pipeline and robust clinical development. With that, I'd like to thank you very much for your attention.
We'll discuss whether there's some light at the end of the tunnel. These are my disclosures for today. We are all very well aware that there's a durability issue if you compare EVAR versus open repair. After a couple of years, we see more problems than with open surgery. This was first, or at least clearly realized by the group of Mark Schömelhorn, and he published this in 2015 in the New England Journal of Medicine. And he noticed that the group that had endovascular repair had more ruptures and secondary interventions than the group that had open repair. Just a year later, the EVAR-1 trialist showed that again in this very well-known publication from The Lancet. You can see the lower two lines in this graph that if we look at all-cause mortality, there's no difference between the two techniques. But the upper two lines show you that aneurysm-related mortality is clearly and significantly more common after EVAR compared to open repair. So there's a durability issue with EVAR, and the most common failure mode of it is loss of proximal seal, especially after implants in attachment zones that are already aneurysmal. Basically, a wide neck is a durability issue for EVAR. This was also realized by a group that took the GREAT registry concerning excluder devices from Gore and published this in the European Journal in 2018. They noticed that the group that was treated with a wider neck had a gradual increase in type 1A endoleaks, significantly more than the normal necks, and they also showed that that group had an increased mortality, especially after about 4 or 5 years during follow-up. My own group has shown the same and published this in 2017, and we noticed that patients with a wide neck showed far more neck-related events and far less clinical success than the ones that were treated with a normal neck. More on a global scale, we showed the same using the ENGAGE registry, so that was only with Endurant devices, and we showed that patients with a wide neck had a 3-fold greater risk of type 1A endoleaks, a 5-fold greater risk of aneurysm rupture, and a significantly increased mortality. And this study had a follow-up of just over 4 years. In 2019, a systematic review appeared, and they also found that a wide neck was a significant risk factor for conventional EVAR. They almost found a 7-fold increase in type 1A endoleak, a 5 times increased risk of a rupture, and about 1.5-fold increase of all-cause mortality in these patients. So our research showed that the most common failure mode of EVAR in wide necks was loss of proximal seal due to progressive dilatation of the neck, progression of disease. We found a yearly rate of neck dilatation between 4 to 6%. And the continuous outward radial force by self-expandable stent grafts may play an important role here. This drawing tries to explain a little bit what might be going on. So in an untreated aneurysm, you only have the arterial blood pressure as outward force. If you implant a self-expandable stent with EVAR, then it's not only the blood pressure, but it's also the outward force of the stent itself, the radial force, that plays a role in neck dilatation, and it for sure contributes to neck dilatation. If we look at the ALTO or Ovation platform with polymer sealing technology, that is basically different because that stent acts more like a balloon expandable stent. There is no outward pressure on the aorta, and there might be no neck dilatation. Interesting subject, and we look deeper into this. And we noticed that patients that were treated with an Ovation stent graft and were followed for 5 years basically had no neck dilatation whatsoever. Very different from patients that were treated with a self-expandable stent, as shown in this graph. But the Ovation patients had all kinds of necks, wide necks and normal necks. So we thought it might be interesting to look at the ones that were most prone to further dilatation. So the objective of this study was to determine the impact of polymer sealing on neck-related adverse events by studying the 5-year outcomes of patients treated with the largest polymer sealing device, which is a 34 mm ovation device. And our hypothesis was that patients with a wide infrarenal neck can be treated safely and durably with the largest polymer sealing device. We took patients from the ENCORE registry. That is basically a compilation of 6 prospective studies, most of them with a follow-up of 5 years. So the study design was as follows. It's a retrospective analysis of 6 prospectively enrolled studies, almost 1,300 patients, with a standardized follow-up and median follow-up of 3 years. The study group consisted of 242 patients, which was about 20% of the total group, the ones that were treated with a 34 ovation endograft. And the controls were the remaining of the population. Looking at baseline demographics between the two groups, there were basically no differences, nor were there any differences seen in medical history, except for the fact that the group with a wide neck were slightly more smokers. If we look at baseline aortic characteristics, we noticed that the group of patients with a wide neck had slightly bigger aneurysms, although clinically not really relevant. The proximal neck length was significantly shorter in the wide necks, and obviously it was wider than the group with the normal necks. Technical success, procedure time was all the same between the two groups, and there was a slight difference with more patients have bilateral percutaneous access in the small neck group, the normal neck group. Looking at the results, we noticed that there was no difference in in all-cause mortality nor in aneurysm-related mortality, completely the same between the two groups. The rupture rate was exactly the same, very, very low, and the conversion rate the same, very low, and no difference between the two groups. There was a difference in type 1A endoleaks, with more type 1A endoleaks in the patients with the wide necks. But as you can see here, that was only on the first postoperative scan, so the 30 days to 3 months scan. Further on, during time, there were no increase in type 1A endoleaks. Proximal device reintervention, very low in both groups and no significant difference. So now switching from ovation to ALTO, which is the new platform and which just received CE mark about 2 weeks ago or so, we can see that the difference is basically that the first polymer ring has gone up. There's only 7 millimeters between the top of the fabric and the polymer ring. That used to be 13 millimeters. So that is supposed to be adaptive seal, which conforms to the neck anatomy just like ovation does. It has very low profile, only 15 French outer diameter, and a broad indication to treat a wide range of patients. And as shown before, because it's exactly the same sealing technology as ovation has, it has demonstrated 5-year durability across all sizes. So in conclusion, EVAR using proximal polymer sealing does not seem to induce neck dilatation like other endografts. In contrast to self-expanding EVAR devices, patients treated with the largest device do not suffer from more complications compared to standard diameter devices. And this analysis suggests that polymer sealing technology is a durable EVAR option even in the patients with a wide neck anatomy. Thanks so much for your attention.
Thanks, and it's great to present our first commercial implant of ovation ALTO in Auckland, New Zealand. These are my relevant disclosures. Just to remind you that ALTO represents a major generational advance in the ovation technology, with the sealing ring being shifted to the top of the graft, just the middle of the sealing ring lying 7 millimeters below the top of the graft material, and this allows us to treat challenging neck anatomy, and particularly a reverse taper and conical necks. I won't play this video introducing the case from the procedure, but this was a 75-year-old male with a 57 millimeter aneurysm, Otherwise, conventional anatomy, apart from small caliber and very tortuous external iliac arteries that represented an excellent indication for ovation ALTO. As you can see in this movie, I'm pointing to the outer deployment knob, and that actually marks the ipsilateral limb. So from the right groin, we're bringing the device up in a reverse orientation. So the ipsilateral limb on the patient's left, and that's really to facilitate contralateral limb cannulation or gate cannulation. You can see the tortuous external iliac arteries that produce some resistance, but the 15 French hydrophilic coated OD of this device allowed us to deliver without too many problems, unlike many devices I think would really struggle in this particular anatomy. Before I play this mid-crown deployment movie, you can see the orientation of the graft, some markers below the proximal nose cone where you can see there's an exclamation mark. That marks the ipsilateral limb, so that's on the patient's left in this case with a reverse orientation. We're then going to deploy the mid-crown.
That one.
Yep.
And you
The
can
mid-crown
see that,
segment. So Andrew's just deploying the mid-crown segment here. And you can see the mid-crown segment is opened up. You can also see that the markers still look pretty well aligned.
Yeah, so then we actually use the integrated balloon to open up the mid-crown segment, around 5 mils of contrast and saline. You can see here being injected by hand to open up the mid-crown segment. And you can see we've used a little bit of craniocaudal angulation to align the markers at the top of the graft material. And you can see with 5 mils that these open up very nicely, and then we can aspirate that. But we've now deployed the mid-crown segment. This integrated balloon is used not only to open the mid-crown segment, but also to mold the sealing rings later on, as we'll see. And there are some other potential uses for this integrated balloon. Now we're going to bring the deployed mid-crown segment down into a position. Remember, this has no hooks in the mid-crown segment or barbs, so it's very easy to slide the mid-crown segment or the entire graft with the open mid-crown segment down into an optimal position. And you'll see under fluoro with the image overlay, I'm just starting to bring that down. It's very easy and very controlled. You can see I've still got the reverse limb orientation by that exclamation mark, and we can bring that down into a position. And then once we've done that, we get close to the renal arteries, and then we can do the final positioning, as you can see here. And this is very, very controlled. So the material comes up to the bottom of those markers, so I can put the markers right at the level of the renal arteries, and the top compliant balloon marker marks the sealing ring. So here's another plain film of us bringing it into position, and then we can connect the polymer fill tube and into the with the automated injector. We can see we start filling the polymer rings. The sealing ring at the top here fills first, and then the secondary ring as well. You can see that once the sealing ring is filled, I'm pulling the stiff part of the guide wire back just to optimize apposition of the sealing ring onto the vessel wall, so pulling it back below the sealing ring level. And you can see we've also filled the rings of the limbs. Now, while the polymer is curing for the next 14 minutes, we can cannulate the contralateral gate. And here I'm using a cannulation wire port that's part of the system, either an 014 or an 018 wire. Here's an 014 sparticle wire up and over and actually went down the iliac artery for ease of cannulation. So this proprietary crossover lumen obviously makes cannulation of the contralateral lumen very predictable. Sometimes that can take a lot of time, but it's predictable with this advance. As it turned out, we didn't snare that. I wanted to just show that you can easily cannulate with a catheter from the contralateral groin, which we did. Obviously, you can see that the contralateral limb is a little longer than the ipsilateral limb to avoid any confusion with cannulating the wrong limb. And then an angiogram confirmed we're in the contralateral limb. Now, we usually do the normal length selection of the iliac limbs based on calibrated catheter angiography to show the iliac bifurcation. And then we could deploy the contralateral limb, which we actually did. We got to 14 minutes after deploying that limb, and then we used the compliant integrated balloon to mold the sealing ring, as you can see. Just a movie of that contralateral limb deployment. The top end of the limb is deployed somewhere between the first and second limb rings, and it's otherwise very accurately and easily deployed. We also, here's a plain film of that limb deployed, and then we deployed the ipsilateral limb extension at the same level at the top, and very accurate deployment on the bottom end as well. Completion angiography was fine, and then you can see CT performed at day 2. Looked like we had an excellent seal and a little bit of post-operative gas in the aneurysm sac, but otherwise an excellent appearance and an excellent volume rendered reconstruction. So ALTO's unique design has no reliance on self-expanding stents for seal with its polymer sealing technology and its secure fixation. It's designed for durable repair. In this case, narrow and tortuous external iliac arteries was an excellent indication for ALTO, and we look forward to further real-world experience and excited to see the randomized controlled trial involving ALTO begin enrollment hopefully later this year. Thanks very much. Well, I'd like to thank Professors Matt Thompson and Hens Verhagen for their excellent presentations. Thank you for your attention to this Endologics Symposium, and hope you enjoy the remainder of Charing Cross, Vienna. Thanks very much.